Welcome everyone to the DFMCH Forum. My name is Ann Evanson. I'm a professor in the department and I practice at Verona Clinic. I'm also the faculty director for the graduate professional and capstone global health certificate programs here at the UW. I have the great pleasure of introducing Dr. Tana Chongsuwat and Dr. Sean Duffy, who will be speaking to us today about community-based approaches for building capacity in global primary care. So a little bit more about Tana. Dr. Chongsuwat is a family physician and clinical instructor in our department. She completed her residency at the University of Oklahoma, MPH at the UW, and is currently a third-year primary care research fellow. Her research focuses on community-based participatory research and implementation of global evidence-based strategies to improve global women's health around the world. She currently has partnerships and projects to address disparities in cervical cancer screening in both Uganda and Milwaukee, working with Southeast Asian immigrant and refugee communities. Dr. Sean Duffy is a family physician and assistant professor in our department. He completed his medical school, MPH residency, and fellowship training at the UW. His research focuses on health system capacity building for the treatment of chronic disease and health promotion in low resource settings. This focus comes through the lens of his collaboration with community health workers in rural Guatemala. So thank you, Dr. Chongsuwat and Dr. Duffy. You can take it from here.
Yep, thank you so much for that introduction. We're very happy to be here. I would start off with just saying that I have no financial disclosures and really looking forward to talking about some of the work that we're doing, particularly when it comes to capacity building. We'll focus on task sharing and then how it applies to some of the work that we're doing individually. And so to start with, I wanted to just kind of introduce the problem that globally a lot of countries are facing, especially when it comes to the healthcare workforce and shortfalls around the world, including the US. And so to start with, the WHO has recognized that the healthcare workforce has suffered significantly due to shortages. And by 2030, there's been projections that we'll have a shortfall of up to 15 million healthcare workers. Now, this is really seen all over the world, but it is focused mostly in low to middle income countries. And that is defined by the World Bank based on different measures. And so because of this, there's a lot of difficulty when it comes to addressing certain areas such as rural, remote, and underserved areas, and a lot of reasons behind this. One thing is international migration, which we're familiar with, is sometimes referred to the brain drain. And then there's the lack of capacity for the public sector to really absorb some of these workers. And this isn't focused just around the world, but can be seen also in the United States. And so this can be applied to a lot of areas, and there's actually measures around the US. As you can see here, some of the dark colored states have a number of primary care health professional shortage areas. And we really see that this has been exacerbated by the COVID-19 pandemic. And so with stress, trauma, burnout, and a lot of challenges when it comes to maintaining an adequate workforce, we see a lot of problems when it comes to again, those areas, rural, underserved, and remote communities that need and don't have adequate healthcare workers. And so this isn't primarily just physicians. We see this all across the healthcare allied professionals. So behavioral health, nurses, there's a huge increased demand when it comes to meeting a lot of these vacancies. And so as a result, the WHO has called upon international communities, public health sectors, NGOs, the WHO, the World Bank, all of these organizations to really address this critical need to develop a workforce that can actually sustain and strengthen service delivery when it comes to health needs. And so particularly, I wanted to just highlight this objective 4 because this is actually geared a lot more towards the international communities as well as the research community to focus on strengthening health resources and monitoring and accountability, addressing priority gaps, and really really focusing on institutional and regulatory context for task sharing and skills delegation. And so I bring this up because this kind of transitions into kind of the solution that a lot of researchers are focusing on when it comes to meeting these significant gaps. And so what is task sharing? And so there's a couple of definitions for task sharing, but they all they all are very similar. Sometimes people use the term task shifting when they're referring to task sharing, although in a conversation that I actually had with Sean a couple months ago, task sharing is actually much more of an appropriate term. And the WHO and the CDC agrees upon this definition, where to allow staff who do not normally have competencies for specific tasks to deliver them, thereby increasing levels of healthcare and emphasizing the need for training and continued educational support. And so this is really important because we're not necessarily just shifting the task that physicians or specialists would otherwise do. We're also providing that continuous support, so that training and mentorship. And by doing this, we are allowing for a well-functioning well, to do this, we need to provide a routine supportive supervision as well as a well-functioning referral system. And so some of the benefits with task sharing is it really reduces some of the bottlenecks when it comes to service delivery, increases capacity, efficiency, and all in all, it actually it helps maintain the health and the well-being of the entire healthcare workforce. And so to summarize, so we're basically allowing and enabling a lot of healthcare workers like APPs, community health workers, nurses, midwives, other frontline workers to perform tasks that would otherwise be assigned to like physicians and specialists, and thereby freeing a lot of the responsibilities for them to focus on other things. And this was also something that they used quite a bit when it came to the start of the COVID-19 pandemic. And so how does this apply to some of the work that I'm doing? And so I just wanted to start off by kind of sharing a little bit of a story of how I got involved in this work. And so I family medicine trained, but I've had interest in global health, global work for many years, from undergrad to med school to residency, and have developed partnerships with different organizations. In particular, during residency, had kind of a continuous relationship with an organization in Uganda, which is where a lot of my work really, I think, took off. Prior to then, I was more of an observer, just kind of learning the systems, learning where the needs were. And as I was finishing my residency, I discussed with my colleagues in Uganda and partners and asked them, like, is there a project that you would like me to consider, something that's QI, something that I can work on? And so I was interested in all sorts of things primary care related, and they said cervical cancer. And so I said, sure, I think that's a great idea. It's something that we do in our practice in the US commonly. Pap smears sounds like something that I could do. Lo and behold, it is a huge problem. I was surprised to find out a lot of the challenges when it comes to really implementing cervical cancer screening programs, and closing and hopefully closing the gap when it comes to disparities. And so just for reference, cervical cancer around the world is a huge problem, particularly in low to middle income countries. In the US, we're a lot more familiar with it, but around the world, it's actually the second most common cause of death of women in reproductive age. And so again, looking at kind of the process when it comes to cervical cancer screening, comparing, the United States and other high income countries to low to middle income countries. Again, we're familiar with HPV vaccination, and then recommending screening with PAP and HPV, and then referring for colposcopy if there's any abnormal findings, and then treatment. Well, in LMICs, it's quite different. And so HPV vaccination has become something that is a lot more being a lot more adapted and deployed. A lot of countries have national HPV vaccination programs, particularly in school-based programs. But this wasn't something that was implemented until about 2016, 2018, at least in Uganda. And so a lot of women that are in their 30s that are due for screening weren't previously vaccinated. And so So that would be your primary prevention. And then for secondary prevention, ideally we want to do PAP and HPV co-testing, but Pap smears essentially don't exist. Cytologists and pathologists are few and far between. It takes many weeks to get the results back, and is very high costs that are associated with it. HPV testing, primary HPV testing to triage for further testing is something that the WHO recommends, but that tends to be very costly, and not a lot of labs have that capability of even processing HPV samplings. And then let's say someone does have an abnormal HPV. Ideally, they would go for colposcopy. Again, this doesn't really exist. And so a lot of countries do something called VIA, where you're actually just looking at the cervix with the acetic acid applied, but not having that benefit of a colposcope and that magnification. But one of the pushes for addressing kind of loss to follow-up issues is same-day treatment. So if someone had any kind of cervical changes on VIA, ideally they would get actually same-day treatment to decrease loss to follow-up. And so, like I said, there's a lot of challenges that are related to cervical cancer screening programs in these countries. So we're talking lack of capacity, lack of accessibility, equipment, the costs, loss to follow-up, and then most importantly, as it's related to this talk, is really the human resources and training. And so all sorts of healthcare workers more or less get some education on cervical cancer, but very few actually get any hands-on training during their training, their school-based programming. Like, so nurses, midwives, and physicians, as well as clinical officers or other kind of APPs, it's not really built into their training programs to actually do a lot of hands-on training with cervical cancer interpretation. And so now flipping back to the US, colposcopy training does exist in the US. It's done through a lot of residency programs, some medical schools, but the AACCP does have kind of a comprehensive colposcopy course. It's not mandatory, it's voluntary. They have done some work recently on making it a lot more accessible, especially with online learning. So it's cheaper, it can be done asynchronously, but it isn't something that is necessarily universal, nor is it something that that is required. And so there's a lot of inconsistency in like how training for colposcopy is done, like what kind of mentorship is built in, CME, things like that. There is like a mentorship program. I started this when the pandemic first started, or like right before the pandemic started, and never really finished it. It was very difficult to actually finish. You needed to find like a mentor who's been certified and get X number of exams done in X amount of time and take an exam. And so I found, even for me who, you know, came from an academic institution and still work for one, found it very difficult to kind of meet some of these recommendations for mentorship. And so so how does this relate to how other programs around the world address this gap in colposcopy training, VIA, access to screening? Is something called digital cervicography, which is where a lot of my work comes in. And so really kind of studying how this applies and how this can be used to promote capacity building and task sharing among other healthcare workers. And so it's kind of what it sounds like. It's basically taking images of the cervix. So it's a VIA paired with some kind of digital imaging. Then you can take the images, you can store them, and you can transmit and share them. There are some downfalls in the sense that you only have like some ability to magnify, which like it comparison to like a true colposcope, you can actually magnify up to 15 times. Whereas if you're just taking a regular camera and trying to take a picture and using that as your method, you don't get as much magnification. But as you can see here, it is much cheaper, and nowadays technology in general is getting cheaper and a lot more accessible. There are a lot of programs out there that are trying to develop innovative ways to incorporate technology and making it, again, more cost effective and accessible to some of these programs. So the mobile ODT is actually just a Samsung Galaxy phone that's in this like case that has that 5 times zoom, as well as a green light filter and a built-in app to safely transmit images. You can even bring a mentor in through like a video call to actually have some live feedback. And then like a cell phone with like an extra magnification is also a possibility. And so like I mentioned before, there's a lot of benefits to kind of this method. It really helps promote task sharing. Anyone can do it as long as they have the equipment. You can actually have like a remote mentor. And so a lot of programs are looking towards like providing that initial training, but having that remote mentorship continuously. So, and that could be from anyone that's in the country or internationally to maintain some of those skills, as well as QI and CME. And then the alternatively, you can also send it to a specialist so that they can review the images and give feedback as well. There are some limitations. Technology always comes with a cost, HIPAA concerns when you're transmitting these images. And then there's not a lot of consistency when it comes to like how you obtain the image, like how good the image should be, how to reduce glares, things like that. And so it can be very user dependent. But this can be applicable to a lot of other low resource settings, particularly the rural United States, for any kind of healthcare worker that's looking to actually be somehow securely take images, interpret them, but then get some kind of mentorship and support from specialists that saving time and resources for the patients. And so I'm going to just kind of breeze through this because it's all a lot of numbers, but this is a scoping review that I recently completed, basically looking at any programs in a low to middle income country that actually uses this method, and really understanding how this method is used for capacity building, mentorship, improving sensitivity specificities when it comes to VIA, and how this is really integrated into some of the cervical cancer screening programs. And so my findings basically showed that in about 23 different LMICs, there's 53 different programs out there that really analyzed how well digital cervicography was integrated into their programs. And so this was just the scoping review. It didn't pull out really great numbers when it comes to how does it improve sensitivity and specificity for VIA, but it did talk a lot more about kind of the benefits to both the healthcare worker in their ability to actually perform digital cervicography and interpretation of the cervix, as well as the patient when it comes to providing education and being able to show them images of their cervix and provide kind of that shared decision on the next steps. And so all in all, kind of just broadly the impact of some of this of global health research on cancer prevention. So we know that by studying these things, we can really, in implementing some of these strategies, we can really eliminate some of these delays in diagnosis, any barriers for screening and colposcopy for communities that would otherwise have are underserved or are facing health disparities can really benefit from some of these global health research findings. And this can also be adapted. We can also adapt a lot of other practices that I didn't really get into depth here. So like HPV self-collection, using community health workers, which Sean will talk about in a second, can really help with education as change agents and community leaders to really promote screening. And then applying this as well to other screening methods, other cancers that have that screening can be done at the community level, and overall just kind of supporting a lot of the prevention efforts. And so I am going to pass it over to Sean, and he will talk about here, actually, as I'm talking, let me stop sharing so you can, but yeah, so he's going to take over and talk about how he applies some of these like same findings to chronic disease management. And then we'll have questions at the end.
Thank you, Tana, for that kind of first part of our presentation. And I as well have no conflicts of interest to disclose. And in this kind of second half, I'm going to be talking about several initiatives that I've been involved with that use task sharing for chronic disease management. Obviously, when we talk about chronic disease, there's a lot of different ones to choose from. What do we want to focus on here? So, in particular, the projects that I will be detailing address the growing burden of diabetes and hypertension, which are two old friends that any primary care clinician is very well acquainted with. The projects that I will talk about today have community health workers as a central element. And so what is a community health worker? Well, a community health worker is a frontline health worker who generally comes from the community that they are serving, or at the very least has a deep understanding of that community. And really, depending on the context, community health workers have been utilized and carry out activities across the spectrum of public health and healthcare. I think traditionally they've been involved in more supportive roles, such as providing patient education and care navigation. But in the projects that I will be discussing, we're using community health workers in more direct service, direct care roles. I also want to touch on the concept of mobile health, or mHealth, which simply refers to using mobile devices such as mobile phones and tablets in health programs. And as the number of mobile phones in use and the spread of the availability of mobile internet has really exploded, over the last several decades, along with this, many more health programs, particularly in low-middle income countries, are utilizing mHealth elements. And while the evidence base for mHealth interventions is still still developing, I think there is now good evidence to support that mHealth can improve coordination of care between different elements of the healthcare system, improve referrals, as well as help to improve the quality of care delivered by frontline health workers through clinical decision support. Well, most of my prior and my current work in community health and capacity building takes place in Guatemala. And for these projects in particular, our partner in Guatemala is an organization called the San Lucas Mission, which works in the municipality of San Lucas de Liman in the western highlands of Guatemala. This is a predominantly indigenous community, and the mission's healthcare programs serve a population of about 40,000 people. And these people are split between the town proper of San Lucas de Liman, which is on the shore of a large volcanic lake, Lake Atitlán, and then a number of different smaller rural communities, which are located at lower elevations away from the lake. So the main components of the San Lucas healthcare program include a small hospital in the town of San Lucas and an attached ambulatory clinic. These are staffed by Guatemalan doctors. The healthcare program also collaborates with the University of Wisconsin, as well as a number of other U.S. institutions. And through these collaborations, visiting teams of medical professionals come to San Lucas to provide surgical services, as well as to run mobile clinics in the rural communities of San Lucas. And since 2004, these rural communities have also been served by a community health worker program. These community health workers are known as health promoters, so I'll be using health promoters and community health workers interchangeably. The health promoter program in San Lucas serves the roughly 15,000 people who live in those rural communities. And these health promoters are recruited from those communities. And the program, kind of the core of it, are 6 full-time health promoter leaders, or coordinators as they're called, who are responsible for recruiting additional promoters, training them, and then administering the various healthcare projects. The remaining health promoters, of which there are about 40 of them, work on an as-needed basis, and they receive a stipend for the time that they spend working on the various health projects. So all these health promoters are bilingual in both Spanish and Cachiquel, which is the dominant local Mayan language in this area. And these health promoters have the average of kind of what we might consider a U.S. middle school education, and this allows them sufficient literacy to be able to carry out their responsibilities. They also undergo a basic training to become a health promoter that consists of 1 weekend per month for a 3-year period, during which they learn about basic health promotion as well as the identification and treatment of common medical problems in these communities. So an early cornerstone of the health promoter program was childhood nutrition, and this makes sense because Guatemala has some of the highest rates of childhood malnutrition in the entire world. And this is even more pronounced in indigenous communities, where more than 60% of kids under the age of 5 are stunted. In 2005, around the time that the health promoter program was first started, 1 in 20 kids didn't make it to their 5th birthday. And about half of these childhood deaths were directly related to malnutrition. So in 2009, in collaboration with Stanford University and my mentor and friend, Dr. Paul Wise, who's a pediatrician there, the health promoters started a program of surveillance and nutritional supplementation for children under the age of 5 in these communities. And this consists of visiting each child in each family on a bi-monthly basis, measuring height and weight, and then using the WHO growth standards to identify either kids who are already malnourished or who are at risk of becoming malnourished, providing those families with various forms of supplementation, as well as providing education on how to maximize the nutritional value of family meals, given the limited resources that they were dealing with. And what they found is that it did take a while to train the health promoters to carry out these activities. And one of the biggest kind of humps or barriers to get over initially was learning how to, for instance, use a standard table to calculate z-scores or growth percentiles, and then just chart this on a growth curve. And so the Stanford program had the idea of developing a smartphone application that would do a lot of these tasks automatically and better allow the health promoters to identify kids who were malnourished. And what they found when they implemented this in 2015 is that it significantly reduced the amount of time that promoters had to train to participate in this program. It also made the checks a lot more efficient, and thus they were able to scale up more rapidly. They were able to reach a total program size of 1,500 kids, which represented the vast majority of the kids under the age of 5 in these communities. And this program has been very successful. Since it was first implemented, they have noted a 60% decrease in severe malnutrition, as well as an 8% decrease in malnutrition-related mortality. So in the course of carrying out their work in the communities, the leaders of the health promoter program also noted an increase in the prevalence of diabetes. And in fact, diabetes prevalence has increased from about 5% on the national level in Guatemala in 1980 to probably somewhere between 10 and 15% now. In addition, a community needs assessment done in 2016 found that of those patients in these rural communities who already identified as having diabetes, only about half of them were taking any kind of medication for their diabetes. Only 13% had good control of their diabetes. And so access to care was very poor. And so two of my collaborators and mentors here at UW, Dr. Jim Svensson, who recently retired from the emergency medicine department, and Kevin Wang, who's faculty in the PA program, had in discussions with the health promoters in San Lucas and through their roles as kind of facilitating that collaboration between UW and the San Lucas mission, we're able to successfully apply for a UW Global Health Institute seed grant to try to adapt that successful model for nutrition, where you have the health workers equipped with a smartphone following those kids over time, to adapt that to diabetes and kind of an adult chronic disease model. And I had the good fortune to become involved with this project kind of at that beginning stages and used it kind of as my main project for my research fellowship. And one of our initial tasks was to work with Dr. Raphael Thun, who's the medical director in San Lucas, as well as the health promoters, to adapt existing guidelines for diabetes treatment to the local context in terms of what medications were readily available, what the resources were to deal with potential complications of diabetes, and what would be culturally appropriate lifestyle counseling that we could deliver to patients. We then integrated these protocols into a smartphone application with the help of our collaborators at Stanford, and we ultimately ended up on the ComCare mobile health platform, which is the most widely, or one of the most widely used health platforms for community health workers and other frontline health workers around the world. We then trained the health promoters in the basics of diabetes care, as well as how to use the application and how to conduct point of care hemoglobin A1C testing and blood glucose testing. And ultimately, the model that we implemented includes one-on-one meetings with a health promoter and a diabetes patient. And these meetings, are kind of guided by the smartphone application. The health promoters input patient information into this application, which then uses this information to make specific diabetes management recommendations. Then based on these recommendations, the health promoter dispenses medication, provides lifestyle counseling, and then for patients who may potentially have complications of diabetes, can refer them for an in-person evaluation with Dr. Thun in San Lucas. After each visit, the ComCare platform allows for data to be uploaded to a secure server where it can then be reviewed by a supervising physician to make sure that the current plan of care makes sense for each patient and make any changes as needed and communicate those with health promoters. And then this analysis repeats monthly. So we did an analysis of the initial about 90 patients that we enrolled in this program. And overall, we found that this program led to improved diabetes control. At the 12 months after enrollment, average decrease in A1C was 1 point, and this led to a greater proportion of patients meeting A1C goals. We found that the application provided reliable medication recommendations and that the health promoters and the supervising physician agreed with the recommendations more than 90% of the time. We also found that patients were very satisfied with this program, in particular with having consistent monthly follow-up and with having a reliable source of medications. We did a cost analysis of this program and found that the cost about $118 per patient per year, which is comparable to other published analyses of diabetes interventions in low and middle income countries. So with the success of the diabetes program, we wanted to be able to adapt this to other priority health problems in the rural communities of San Lucas. And so in concert with our Guatemalan collaborators, decided to try to adapt this to hypertension. And just to talk a little bit about the global burden of hypertension, more than 1 of 5 people worldwide has hypertension, and 2/3 of these people live in low and middle income countries. Hypertension is a leading preventable cause of death and disability worldwide. And in low and middle income countries, more than 60% of people with hypertension don't know that they have the disease, and less than 10% have good control of their blood pressure. So given that there is such this unmet burden of undiagnosed hypertension in low and middle income countries, with this hypertension project, while we had focused mainly on treatment of already established cases in the diabetes program, we wanted to also include a component of identifying screening and diagnosis of hypertension with this new program. We also wanted to kind of improve the rigor of our analysis in order to add to the existing literature on task sharing in these settings, and particularly with the use of community health workers and mHealth. And so while we didn't have control for our diabetes program, we wanted to compare this new model to the kind of current standard of care, which is direct physician management. And we chose to use a non-inferiority design because we're trying to show that task sharing is not inferior, is just as safe and effective as the kind of current standard of physician care. And we were able to secure funding for this program through the NIH 4B International Center and a 5-year R21R33 phased grant. So the first component of the program is to improve the diagnosis of hypertension in these rural communities through, again, a community health worker model. And this starts with standardized measurement of blood pressure per international guidelines and using clinically validated arm cuffs. And we also designed a clinical decision support application to help guide the health promoters through a standardized assessment of each patient, including their medical history, whether they're taking antihypertensives, and also to help them to adhere to that standardized blood pressure measurement. In order to assess the accuracy of these health workers in diagnosing hypertension compared to a physician, we plan to screen at least 350 adult patients in these rural communities, and each patient will be assessed by both a health promoter and a physician on the same day, and then we will compare those two evaluations, which are blinded to each other. So far, we have screened 188 patients in these communities. We found that there's 90% agreement between the health promoter and a physician assessment, which is our goal threshold for agreement. And so we're hopeful that this trend holds as we continue to collect data. So the second component of this program is to implement and assess community health worker-led hypertension management. And so again, kind of similar to with the diabetes program, our first step was to create standardized treatment protocols based on established guidelines. And in this case, we used the WHO's HEARTS guidelines for the management of hypertension and reduction of cardiovascular risk. And we then, again, as in diabetes, are programming this into a clinical decision support application, again, on the ComCare platform. This application provides recommendations to the health promoters with regard to initiation of antihypertensives and titration of antihypertensives, as well as the use of aspirin and a statin to reduce the risk of cardiovascular events in patients who are at higher risk. The application also provides guidance to the promoters on the identification of potential complications of hypertension, such as heart failure and ischemic heart disease, as well as lifestyle guidance to optimize blood pressure control and reduce cardiovascular risk. In order to assess this program, we will first pilot it with a small group of patients, about 30 patients, to determine feasibility, as well as to refine our treatment protocols and the application. And then we plan to enroll, to randomize 300 patients to either management by a health promoter with that remote physician supervision versus direct management by a physician, and then compare them with a non-inferiority design with the primary outcome of blood pressure control. So in developing this hypertension program, we really took some key lessons from our experience with diabetes. In the first place, we're using basically the same patient care model, whereby a health promoter will meet one-on-one with the patient each month. They'll use the smartphone application to guide the visit, and then that application also provides the clinical decision support recommendations, and then allows for the remote supervision by a physician. We're also taking steps to try to maximize the scope of care that can be provided in the rural communities. During the diabetes program, we noticed that if we made a recommendation to a patient, for instance, to get lab tests or to be seen in person by a physician in the town of San Lucas, that often the cost and the difficulty of getting to the town precluded patients from actually carrying out these recommendations. And so we have now trained a subset of the health promoters, and I have, as you can see here, donated my arm to that cause into drawing blood, and we have made logistical arrangements for these blood samples to then be transported to a hospital in San Lucas and for them to be processed there in the lab. We've also, we're planning on, rather than for a patient with a potential complication, recommending for all of them that they have an in-person physician assessment, first using a physician teleconsultation with the health promoter and the patient to determine, kind of further triage those cases, make treatment recommendations, determine patients who really are high priority, high risk, and need to be seen in person. And then we also have included more workflows within the application itself to allow for physician-directed treatment that kind of falls outside the standardized treatment protocols. So for instance, if a patient needs to use an alternate antihypertensive that's not part of the standardized protocols, or needs additional medication to manage complications or comorbidities, we're providing workflows within the app to support that. So just kind of thinking about how can we take some of these strategies, these models for task sharing that have been used in low and middle income countries, how can they be applied in our healthcare system here in the US, which obviously is a lot different in terms of the resources available, regulation, scope of care, compensation, you name it. I think there's actually really a lot of examples already of this being done and being successful. I would point to, in particular, pharmacist-led hypertension management within our own health system here in UW Health. So this has been implemented within the past couple of years, and basically it involves patients going to see the pharmacist rather than going to see their primary care physician on a regular basis. And the pharmacists are able to follow protocols to titrate medications, as well as to change to different medications if patients, for instance, are experiencing side effects. And this has been rolled out across UW Health primary care pharmacies. And they did an analysis looking at, of all the patients who were eligible for this program, of those that chose to participate in the pharmacy hypertension program, 74.5% of them achieved blood pressure control compared to 41.35% who are following basically standard care pathways. So that's really an impressive result. And I think also this PCPs and other clinicians in our primary care clinics have been understandably very satisfied with this collaboration with the pharmacists. And there's also been a desire to expand this model to diabetes care. I think that the use of community health workers is another way that we can adapt approaches from elsewhere to disease management and other health problems in the U.S. And actually, there is a pretty strong evidence base for using community health workers in high-income countries like the U.S. across a variety of different health outcomes, and also evidence that these programs can reduce health disparities and reduce healthcare costs. And just to provide another recent local example of how community health workers can enhance healthcare and allow for task shifting was the UW Prevention Research Center community health worker project that was undertaken during the COVID pandemic. And the UW Prevention Research Center partnered with multiple community organizations that use community health workers like Centro Hispano and the We Rise Black birth workers. And they provided training and some standardized tools to help to these workers with community-wide scale-up of COVID-19 testing, contact tracing, and vaccinations. And then they published this toolkit and are hopeful that it can be adapted to other settings as well as to other public health problems other than COVID-19. So again, just to kind of summarize the overall points and the ways in which I think these task sharing approaches can help to address the healthcare workforce crisis that we are facing in the US and around the world. I think the overall message is that this can be, task sharing can be effective in addressing this work shortage, and that it can be particularly effective when we're using organizations that are deeply embedded within the communities they're serving, workers like community health workers who come from those communities. I think that pharmacy-led chronic disease management is a widely intact resource, and that it could be used to really improve chronic disease management and also free physician and other clinician kind of manpower and time to deal with more complex cases. And finally, that we should take successful global practices and technological innovations, such as Tana discussed, the digital cervicography that were really tested and implemented in low and middle income countries, bring them here so that we can improve capacity building, training, and mentorship, and increase access for these essential services for patients in medically underserved areas. So with that, just to kind of provide some of our acknowledgements as far as current funding and partners that we'd like to acknowledge, and then I think at this point we'll open it up to questions.